Brodsky, my colleague and section head in speech-language pathology. Dr. Brodsky completed his bachelor's and master's degrees at Michigan State University, his PhD at the University of Pittsburgh, and an additional master's in science at Johns Hopkins University. He comes to us in 2022 from Johns Hopkins University. He's a fellow of the American Speech-Language Hearing Association. And he's going to talk with us today about the past, present, and future of speech pathology. And his clinical areas of interest are swallowing disorders in adult populations. And his research interests study the effects of critical illness and critical care medicine on swallowing in the airway. So we're delighted to have you as part of our group, Marty, and welcome to Head and Neck Live.
Thank you so much for giving me the opportunity to talk. I think I'll just share my screen here. I hope everybody can see that and still hear me. Okay, so when I was originally asked to give this presentation, it has morphed probably a few times since we first began, and I actually have more material to present now, having been in this seat since October. So it has been an absolute pleasure to join the Cleveland Clinic and to learn from every single person that I come into contact with about the history of the organization, how things work, and even the day-to-day. So it has been a fantastic experience so far, and I continue to look forward to that. Get the stuff out of the way here. Here are my disclosures. There's nothing in this talk that's going to interfere at all with anything that you see on the screen. So where I think Jamie and I landed was to give a brief autobiography that actually Paul gave me just a short while ago. I'll add a few little tidbits there. And then kind of a broad vision and the research that I'm doing and that I anticipate to do. And then certainly the plans for the speech-language pathology section within Head and Neck Institute. So why don't we begin with a little bit about me, and I will promise that this is brief. Anybody who knows me knows that I don't like to talk about myself, so this is going to be a little bit more of the same. As I was introduced, I actually grew up in the Detroit area in the northwest suburbs. Spent about 28 and a half years there before I moved out of the state. But before I did that, of course, I went to Michigan State for both my bachelor's and master's in communication science and disorders and speech pathology. After about 4 years working in the Detroit area, the last 2.5 years in a level 1 trauma center with the Detroit Medical Center, I moved to the University of Pittsburgh to do my PhD and spent about 3.5 years there. And left ABD, if you will, everything but my dissertation, down to the Medical University of South Carolina in Charleston, where I spent 6.5 years down there in the otolaryngology head and neck surgery department, working alongside my mentor, Bonnie Martin Harris, whose name you might recognize from the modified barium swallowing impairment profile. That was actually her K23 work via NIH and NIDCD that I was very fortunate to be able to work with her on. So after doing that and spending a lot of time in head and neck cancer, as you can imagine, down in the tobacco beltway, if you will, of America, I came up to Johns Hopkins University and spent about 15.5 years there before moving about 370 miles west back to the Midwest and Cleveland Clinic. And essentially, as I said, I'm very grateful to be here, and everything that came before Cleveland Clinic kind of prepared me for what Cleveland Clinic is, and here we are. So as a clinician during those times prior to my PhD, my adult practice was never pediatrics, except during my clinical fellowship year. Outside of my clinical fellowship year, everything has been adults. And I've been in each of these different types of placements with regard to adults in terms of inpatient, outpatient, inpatient rehab, and extended care facilities. Essentially, I got to see a pretty broad continuum, as you can see, of the care line. And the primary focus there was neurologic communication disorders in all the ways that you know speech language pathologists to work with them. And that would be aphasia, apraxia, cognitive communication impairments, right hemisphere kinds of things, TBI, dementia, and all types of cognition that you see in the hospital. Certainly dysarthria, and then dysphagia. Even though it was on the scene, for me, it was pretty early in my career where I didn't get a lot of it until I actually came into the extended care facilities that led to the inpatient acute care areas. I was primarily relegated, if you will, to neurologic communication disorders, even to the point where I started memorizing the Boston Diagnostic Aphasia Examination auditory comprehension section and the paragraphs and the sentences that were associated there. Finally, as I said, I moved into head and neck cancer in this area as well as part of the patient mix, and certainly part of my training during my doctoral career or doctoral training. Head and neck cancer really didn't take a hold of me until I moved to South Carolina, where I was completely immersed in it, as everybody in otolaryngology head and neck surgery is. So that's really where I began in head and neck cancer. And moving out of South Carolina, the way things were set up at Johns Hopkins is that there was a clear distinction between the physical medicine and rehab SLPs and the otolaryngology SLPs. And as you can imagine, the otolaryngology SLPs were the ones to handle head and neck cancer. And me being in a physical medicine department, there was an absolute dearth of these types of patients for the last almost 15 years. So now I'm returning to, obviously, the otolaryngology area, where I'm seeing a little bit more of that. But in my clinical practice in H&I, most of the patients actually are not head and neck cancer. They're coming in with complaints like globus, post-stroke, post-extubation from ICU, and I would say general practice otolaryngology. So that was me as a clinician during all of the years after I left graduate school. I have never not been a clinician. I'm a clinician at heart. But with that said, I obviously have my PhD and I am a researcher as well. So, and part of research is really to focus and dig a lot deeper beyond the very broad populations that we serve as speech language pathologists. So as a clinician researcher, what I've done is seen the spans of everything from healthy subjects to inpatient and outpatient individuals. And primarily in these three areas, and in these three areas temporally as well. So understanding the role of cognitive resources in language, memory, and swallowing, that was actually my dissertation work. And basically it was just very briefly a dual task paradigm where you're doing effectively two different things, trying to determine what resources you have to be able to do both at the same time. One of the parlor tricks that you can use on the weekend with your friends is have them draw a picture of a house and sing happy birthday at the same time. And what you'll realize very quickly is that it's a little bit awkward at the beginning, but it is very able to be accomplished in that sense, in that you can draw a house that is nonverbal, and you can sing happy birthday at the same time. And the two tasks largely do not interfere with each other. They're in two different sections of the brain, handled by two different areas of motor input and output. Separate that by writing the words to the Star-Spangled Banner while speaking or saying or singing happy birthday. And what you'll find immediately is you're not sure which to do first. And it's always the two competing against each other. So that was the nature of my dissertation. It was this thing that we consider reflexive, automatic, vegetative in swallowing that we don't think is going to be interfered with anything that's cognitive. And that, in fact, was not the case. If you were to take patients who have Parkinson's disease, for example, idiopathic Parkinson's disease testing absolutely normal on cognitive screenings, you will find that there is a trade-off in their ability to handle both swallowing and listening and moving their foot to respond to a stimulus at the same time. And as the staging of Parkinson's disease increases, this becomes more and more apparent to the point where stage 3, stage 4, as you can imagine, are quite difficult. And certainly it affects people in stage 2 as well. So even though you think that Parkinson's disease, idiopathic Parkinson's disease, and the way James Parkinson referred to this in his original work as being absent of any cognitive problems in these folks, there may very well be issues in these folks that are subclinical. And that's kind of what we learned in my dissertation. From there, I moved very swiftly with, again, my mentor, Bonnie Martin Harris, moving into the advancing of understanding swallowing physiology, formal assessment, and bedside screening. And as I said, our work dealing with the modified barium swallow study did come into play at that point. So I will get into that in a little bit later. Okay, moving on, the last area, understanding swallowing impairments and laryngeal injury after oral endotracheal intubation, was something that I had been wanting to do this entire time, from the time of even before my dissertation, which is what prompted me, at least in some sense, to go back for my PhD. Unfortunately, there was never the support, never the resources, never the opportunity to be able to work along these lines and move forward with this area of research until I got to Johns Hopkins, and frankly, until I was funded on a KL2 that put this formally into place. So I've been doing this about 12 years, give or take. And I don't see that changing anytime soon. It is an absolute passion of mine, and it is something that I am really wanting to push forward in terms of an area that's pretty much a dearth in speech-language pathology. People have certainly taken a look at this area, but nobody's really taken a deep dive into this area, and it's pretty wide open. So it's a very wide open and a very strong passion of mine to move forward. In all of these areas of research, I have taken a look at a broad spectrum of patients through the years, whether it's stroke, head and neck cancer, progressive neurological disease, certainly critical care, and recently COVID-19. We're still working on projects along these lines. Much of the research that we're doing on the grants I'll tell you about deal with these patient populations. And I will be pursuing writing pretty quickly in these areas as well. A lot more writing, certainly in the critical care area and the COVID-19 area. Before I get into the grant-funded research, some of the investigator-initiated research that is unfunded and still remains with collaborators at Johns Hopkins extended to the University of Kentucky and the University of Texas Health Sciences in San Antonio. We're currently working on the outpatient water swallow test. Some of you know this as the Yale Swallow Protocol. Essentially, it's a minimal cognitive evaluation that has 3 commands, 3 questions for comprehension and the ability to answer them, followed by the pursuit of 3 ounces of water swallowed continuously from a cup or a straw. Effectively, it is reported to be 96.5% sensitive, about 46% specific with regard to screening patients with aspiration. So we took a look at this as concurrent validity with the modified barium swallow study. And that was the work that we presented at just this past March at the Dysphagia Research Society meeting in San Francisco. This, in fact, was the poster. And for all intents and purposes, what we found was that across 2 sites, ours at Johns Hopkins and the University of Kentucky, in just over 100 patients, we found that there is very strong concurrent validity, meaning that when you take a look at 3-ounce water swallow done clinically within 15 minutes prior to the barium swallow study, you get effectively the same results in both sites. And you can see these areas under the curve are very high. And of course, the concurrent validity across sites and overall was again very, very high. So effectively, when the test tells you that the patient has clinical signs of aspiration, you can pretty well believe it. When the test is absent, you can pretty well believe that too, were the findings. They're very strongly associated. The Yale Swallow Protocol is very strongly associated with the Veribar 3-ounce swallow as the reference standard. Now, I want to point out here, some have said that because you're adding barium to water and mixing that concoction, if you will, in radiology, that concoction itself is very different in terms of viscosity, meaning that it approaches somewhat thicker liquids than simply water. Despite that, this research says that they can be treated almost identically. And that you can pretty well believe the research in terms of the sensitivity and specificity of what we know as the Yale Swallow Protocol in an outpatient population. Okay, moving from that, as I said before, I'm still working on a project. It has been a long retrospective project taking a look at patients who are historic controls with ARDS, those absent and at the same time as the COVID pandemic, matched with patients who have COVID ARDS in ICU. And we're taking a look at whether there are any differences in acuity, differences in swallowing relative to tracheostomy when compared with those who are orally intubated. And at the moment, we're currently cleaning and analyzing the data so that we can present those data. So unfortunately, I don't have that information just yet, but it is forthcoming, and I hope within the next 6 months to a year that we'll be submitting actual manuscripts. So something to look forward to, and perhaps a future H&I Live or another presentation. Getting into the funded research that I've had, as I said, I started for the last 12 years or so working in critical care. This, in fact, was my K-23 called Preventing the Effects of Intubation on Deglutition, or the PRESIDE project. As you can see, it ended years ago, but smack dab in the middle, just before the pandemic. And we were waylaid with regard to the IRB. We had not met our recruitment goals. And it was, as you can imagine, very difficult to get this research moving. In the end, we ceased the project before the recruitment goals, so we don't have as many subjects as we wanted. Despite that, I don't know where the power is and whether there are going to be any significance, but at least we'll have an insight as to the whole point to this. And this was a non-randomized clinical trial whereby patients came in as controls and patients came in as those who were actually going to be treated pre-extubation in the ICU. And they were going to be treated in a way to work on tongue strengthening. I was doing sensory electrical stimulation, so threshold, if you will, neuromuscular electrical stimulation. We used, in plain terms, the vital stim device, but at levels that were minimal and only had the sensory effects. So effectively, patients only felt the buzzing and the tingling. There was no neuromuscular involvement with these patients. And probably for obvious reasons, you don't want to mess with anything in the airway when you've got an endotracheal tube present. Then the patients, once extubated, were evaluated via FEES to take a look to see whether they were aspirating. And the whole point to this was to get to these patients in a prehabilitation format to prevent aspiration post-extubation. Again, I'm going to have to dangle the carrot in front of you there. We are cleaning the data right now. We're almost ready to analyze the data. We're finishing up that pretty quickly, and then I'll be able to start publishing on those data. Kind of concurrent and on the heels of the K-23 project, the current project that is still going, and now we're into the NCE period, or the no-cost extension period, is the R01 that I have with my colleagues Dale Needham and Vincia Pandian. Dale Needham is an intensivist in the medical ICU at Johns Hopkins, and Vincia Pandian is a PhD nurse, also working in critical care. She's actually the former head of the trach team at Johns Hopkins, and now has turned more academic, working in the School of Nursing, and is an assistant dean in the School of Nursing. Great colleagues, multidisciplinary PIs, all working to take a look to see what does post-extubation laryngeal injury really look like, what is the breadth of the injuries that are out there, and to put the FEES in place at the same time, or the endoscope at the same time as the 3-ounce water swallow test, to attempt to replicate the results of the original study that Deb Suter and Steve Leader did in 2008, dealing with the Yale Swallow protocol and the 3-ounce water swallow test. So we've gotten all of these points. This has been a 5+ year project. There are 365 patients that were enrolled. We have data, I believe, on 265. And all on laryngeal injury, swallowing, and voice, both acoustic and perceptual voice. So I've got colleagues in otolaryngology, head and neck surgery within the SLP team who are helping me out with that and analyzing those data. I've got otolaryngologists at Johns Hopkins evaluating the laryngeal injury, blinded review, and then reconciliation where there are differences. And then swallowing is more of the SLPs, both in ENT as well as PM&R. So this has been a very large project with a lot of people involved through the years. Very grateful for all of that. But in this moment, enrollment closed June 6th, I believe. and we're in the process of cleaning the data, starting to analyze the data. We have just submitted 2 papers, not the major papers, but we've submitted 2 papers, and we're starting to present the results of these data. So more on that a little bit later. Most recently, we were funded on an R13 project, which is kind of a one-off project, if you will. This is a $50,000 grant. It's a small grant strictly used for conferences. And the whole point behind this was to find or to identify through consensus, very large panel, the term dysphagia. If you can imagine, I mean, dysphagia has been around since at least the 1800s, the late 1800s, where Francois Magendie started talking about that and the difficulties people have with swallowing. Fast forward, here we are more than 130 years later, 150 years later. We still have a definition of dysphagia that is all over the map. And of course, the direct results of this are coverage in this country with regard to third-party payers, government payers, how it is that we talk about it, what is it that we're researching, et cetera, et cetera. It's a little bit of a messy area. So we came up with the idea of let's see what we can do to kind of hone in on an actual definition here that we can get people to agree in and buy into. And hopefully we'll have something in the end where we can start converging on a final definition for the term dysphagia. So my colleagues, Deborah Suter at the University of Kentucky and Giselle Carnaby at the University of Texas Health Sciences San Antonio, and I applied for this R13 grant. We just had the conference in Lexington, Kentucky that had just over 30 clinical researchers with actual representation from not only myself at Cleveland Clinic, but Steve Insler was there as well and participated in the conference and the modified Delphi that we put forward there. Next year, next fall specifically, we're looking to disseminate the information that we got from the conference, finish up the scoping reviews that we're doing on the definitions of dysphagia, and complete the qualitative research that's being done based on everything that has taken place between those two, and disseminate those as I said, next fall. We're looking at Philadelphia. We'll see where that goes. This is going to be a broad conference. Everyone is welcome there, whereas the consensus conference that took place a couple months ago at this point was closed to only the people involved with this information. And of course, we're taking a look all 5 of those domains: screening, diagnosis, treatment, quality of life, and ongoing care within the aging population. So this was funded by the National Institute of Aging, and that's the focus here. Perhaps in future work, we'll expand that out to the non-aging population, or in the work that we're doing right now, we may find qualitatively that it may not matter. Again, to be continued. I don't have results at this point about that. That's an ongoing project. Finally, the last bit of funding that I have has been going for about 1.5 years, almost 2 years now. This was through the Johns Hopkins University Center of Excellence in Regulatory Science and Innovation. They nicknamed that CCC. It's a cooperative agreement, not a grant, with the FDA. My colleague, Caleb Alexander, is the PI on this project. He's the one who applied for the U01. We have a sub-project of the U01, which is this cooperative agreement, which effectively is put forth an idea, see if it flies by everybody in terms of what they would like to do. So Caleb and the FDA and their coordinators had a buy-in as to whether we move forward with this project. And then as we're moving forward with this project, We have very frequent touches with the FDA, and they help steer the project. So this is not investigator-initiated, investigator-controlled, if you will. This is a cooperative agreement in that essentially it's a compromise on everything that's done, on what's done in the first place, and then every aspect going forward. So we've worked very tightly with the FDA along this lines. And the original project is, in fact, somewhat different from what was originally put forward. What you're looking at, the title of Understanding and Measuring the Progression of Dysphagia in Patients with Parkinson's Disease, was originally to take a look at these folks on X-ray from stage 1 to stage 4, and to plot the progression through the timeline that is dysphagia from onset within the Parkinson's disease through senescence and the end of Parkinson's disease. That, in fact, was completely kicked out. That is not the goal now. The goal now is to do the scoping review of these patients, but we've also added 2 additional patient populations, and that we're talking about ALS, and we're talking about Niemann-Pick type C disease, which is a lysosomal disorder. So there's a lot of learning in the 9 colleagues that I have working on this project. Essentially, if anybody has heard of Niemann-Picks in the first place, and I can tell you, I think there's only 2 of them, and both of them are neurologists. Nobody has ever seen a patient with this kind of lysosomal disorder. So this is going to be new information for everybody, and we're moving forward with that. The scoping review is taking a look at all 3 of those to find out what's known in the literature about the lived experience with dysphagia and voice and speech problems with these patients. The second part of the project, the more research-oriented part of the project, primary data collection part of the project, is taking a look at the lived experience of these folks and interviewing 3 sets of subjects. The first one, of course, is going to be the patients with each one of these diseases. The second is going to be the caregivers for them, so their spouses, their family members, people who actually take care of and help their rehabilitation. And then finally, the providers, folks like you and me, clinicians who are working with these patients on a frequent basis. So jury's still out on this one. As I said, this is an ongoing project, and it's going to take a long time beyond the August 30th deadline of the original cooperative agreement. We've worked with FDA, and they are going to give us a no-cost extension, although I think most of it's going to be free because we were told not to expect an NCE, that's something that's handled in the last minute. So we've got some funds to continue forward, but most of it is going to be the gracious volunteerism, if you will, of everybody on the project. All right, so that's me. Enough of that. Broad vision and research for the section of speech-language pathology kind of looks like this. For those who are working on research, the SLP interests so far that I've seen are head and neck SLPs currently participating as a site for a multi-center study with MD Anderson and University of Toronto. Those are folks working on outcomes in patients with head and neck cancer. So that's one project. Collaborations are currently going on with Case Western, including myself as well. I've got a meeting after this to talk with one of the collaborators I've had through the years over there. And then finally, and very specifically in other areas, voice, transgender, and now food textures are interests of the SLPs that we're working with, that are working in H&I, and each of them pursuing their own research with their own collaborators. So we are moving forward with some research in the section. I think most people are open to assisting with research in the section. So if something comes your way and you're interested in moving forward with research, please don't hesitate to contact me, or certainly reach out to the speech-language pathologist who might be of interest with your study very directly. We are open to that, and I'm certainly encouraging and supporting research as much as I can within our section. My personal collaborations within Cleveland Clinic specifically, first to kind of commingle with each other almost simultaneously. The MICU and the CB-SICU directors came to me and they said, we want to increase the use of fees and do some improvements, clinical improvements in our patient populations. Can you help us? So we're moving forward as much as we can, trying to get the pieces all into place with those projects in this moment. I will give the shout out to Rachel Barakis, who has been instrumental, and I mean that literally and figuratively, in training and reorienting the SLPs in our section with fees and getting them moving in the acute care area, as well as kind of the person that's helping coordinate this with Brian Hedman and myself. So thank you to both of them for their assistance with this project, and certainly all of the SLPs who are getting trained and seeing these patients in the acute care wings of our hospital. Right now, I personally have an IRB submitted with Will Tierney, and we're looking to continue both of our interests in post-extubation dysphagia and laryngeal injury. It was a very pleasant welcome to find out that Will had interests similar to mine, and it was kind of the unknown marriage of research that could be and now is, and I'm very grateful for his collaboration and the others that will be on these projects as well. So that's what's going on in our area. And kind of looking forward to speech-language pathology in the next several years. These are the things that I presented in my colloquially titled State of the Section for speech-language pathology a few months ago to the SLP. So if there are SLPs who attended that meeting, this will sound a little bit familiar, a little bit tweaked for this presentation and updated relative to my original presentation back in our section. So one of the big things kind of in the crosshairs and the interests of the SLPs who are working very specifically in the neurological communication disorders is the Neurological Institute that's currently being built. As everybody knows, we're getting a very large $1.3 billion building on the west side of our campus, and it will house all of the neurology patients in the acute care wings, as well as being seen in outpatient and outpatient rehab with CCRST. Brian Hedman and I are working to coordinate with the Neurological Institute in an attempt to prepare for its opening that will take place in late 2026. We believe December 2026 is the target date. And although they won't have all 218 beds open at that time, I believe the number is right around 160 or thereabouts, 160 to 170. We still need to plan to staff that in terms of speech-language pathology. We need to get and work with and identify the spaces that we'll be in and what the flow will be like. And kind of plan for everything that we currently do, but in a different building. So it's very exciting, and more to come on that as we learn more about where the Neurological Institute is going and what they'll need from us. The half statement there was not a half thought. It was supposed to increase our staffing probably 3 to 5 SLPs right out of the gate to deal with about 160 to 170 patients that will be in this building. And as you can imagine, neurology is kind of the bread and butter of speech language pathology, similar to head and neck and otolaryngology. Essentially, anybody who has a stroke, progressive disease, TBI, or neurological event has the potential of having speech, language, voice, and or swallowing disorders. So this is going to be a very heavy demand on speech language pathology, and we'll need to kind of brace ourselves and plan accordingly in terms of how to staff it. I don't have the magic numbers right now. I don't have a magic equation that if there are X people, we need to think about this. But that's going to be ongoing in discussions. So more to come about that. In terms of the next year's goals, we wanted to expand the FEES program. When I first came in, essentially Rachel was the only one doing FEES in the acute care wings, and in the outpatient wings, we had essentially most people doing FEES. So less concerned about outpatient. We've got a 1,400 bed hospital that we need to work with, and only one person doing FEES. There was give or take anywhere from 5 to 15 FEES being done a month prior to implementing this FEES program that, as I said before, Rachel has been phenomenally instrumental with. And we have expanded that to now we're upwards of 3 or more people who are fully trained in FEES and are extending out into the acute care wings. And now we're averaging on the order of about 30 FEES per month across all of the inpatient beds. So this has been a huge success so far. It has been a mountain of a climb to get to this point, but huge success. And shout out to everybody involved with that project, and certainly all of the SLPs who are or will be trained in FEES to be able to do this. Along these lines, we're looking to hire more SLPs in the inpatient area and imminently. Brian and I just submitted for increased FTEs within the acute care area, and we're looking for additional coverage with Walker as well. In the upcoming months, hopefully you'll be able to see a couple new faces in our section, and I'll be happy to introduce them to you. In addition to the new SLPs, because FEES has really taken on a life of itself, we need some assistance in being able to accomplish this. As you can imagine, holding a scope and feeding a patient who's not capable of feeding themselves is quite difficult. So 2 sets of hands are necessary for this procedure, unlike the radiology procedure of modified barium swallow study, where it's simply the SLP feeding the patient and viewing the screen. This actually requires 2 people, so we are working with the administrators to get an assistant, whatever the name of that person might be, to be able to assist us in the acute care wings. And that person may also have a dual role with other folks in H&I. So kind of a to be continued. The modified barium swallowing impairment profile that I spoke about earlier, wanted to first update all of the SLPs. They've all been trained, I believe, or at least most of them have been trained in the MBS-IMP. And to give you some idea of what that takes, it's hours of training and a test where they are tested against a gold standard and need to show 80% reliability in order to use that as the scoring system. Everybody who uses that is indeed 80% or greater in reliability with the system. So the information that you're getting, whether it's SLPA or SLPB or SLPC, they're going to be seeing the very same things. They're going to be communicating the very same things, and they're going to be scoring it within 80% reliability or greater within everybody, not just within Cleveland Clinic, but worldwide. There are more than 50,000, more than 15,000 clinicians, mostly speech language pathologists worldwide, who are trained to use this. So we're going to be bringing in an external speaker. That speaker will be Bonnie Martin Harris, to speak very specifically with our group, and to kind of bring them up to speed, answer questions, and introduce them to each other so that we can all work collaboratively toward perhaps some research that might be on the horizon. And then finally, one of the goals is to, interestingly enough, have access to thickened liquids that are maintained in the nutrition rooms that are on the inpatient wings of the main hospital. For whatever reason, these are not immediately accessible. These are things that need to be ordered and brought up on trays from the cafeteria, or brought in by the SLPs from their stash somewhere in their offices. This is not maintained in the nutrition rooms, and certainly reduces access for anybody who's on an altered diet for thickened liquids, as well as reduces the potential for safety in pill swallowing, medication provision, and so forth. So whatever we can do to kind of help that and move that forward is a goal for this year. Within 2 years, again, we're looking to continue growth of the fees program, and very specifically, very largely focus on the ICUs as well as the wards. The ICUs have been very largely dependent on the modified barium swallow studies, but as you know, the accessibility of critically ill patients to radiology requires a number of people to transport the person, coordination with radiology, and certainly a lot of external work separate from the assessment that needs to be done. So if we can move in the direction of fees, which is the whole point, in that we can schedule this ourselves, we can work with this on our own timelines, and that we can approach these patients at the bedside without moving them, there's a huge reduction in the resources necessary to assess their swallowing. The bonus of using fees, as you can imagine, and certainly in patients post-extubation, is taking a look at firsthand what laryngeal injury looks like. So with an increase in our fees program, you are likely to see increases in the H&I referrals for taking a look at patients with post-extubation laryngeal injury, if nothing else. Brace yourselves, because we are growing that program, and you may see a little bit of a surge of consults coming your way for those who take care of that. We are going to continue to try and increase coverage for the SLPs within the inpatient area. Certainly outpatient is on the radar. I don't want to negate them or overlook them. We are actually, even just last night, I was in conversation with others talking about expanding our outpatient coverage as well. So all of this is on the radar. Nothing's being ignored, but specifically the focus that I had addressed was to increase the coverage on the inpatient side. As you can imagine, within 2 years, we're going to need to prepare ourselves for the Neuro Institute. That's going to become more and more imminent as time goes on. We'll kind of brace ourselves a little bit. My goal is also to establish what I'm calling, and it will probably take 70 different names before we finally end up on a name, but the Cleveland Clinic Swallowing Airway and Voice Summit that will cover swallowing, airway, and voice issues of all sorts, all patient populations, and will be presented by and hosted by the Cleveland Clinic folks, certainly within our Head and Neck Institute, dealing with all of these areas in a conference that at the very least, might be biennially, possibly annually if we have that kind of interest. So something to look forward to. It's just been a discussion at this point. Anybody who's interested in that, please contact me. I'd love to work with you and see what we can do to move that forward. And then finally, I want to push forward and continue the support of all of the SLPs who are working for, and those who haven't even started yet, working at research and presenting to major conferences to disseminate the work that we're doing and hopefully to better patient care around the nation and around the world. 5-year vision is a little bit more of the same in that we're continuing to grow both in inpatient and outpatient SLPs. We're looking to grow our education program as well, in that we're looking to bring on not one, but more than one clinical fellow for inpatient as well as outpatient areas. And whether that's pediatrics, ICU, voice, head, neck, whatever it may be, to be continued in terms of interests and approvals. We'll see where that goes. And then, of course, bringing in multiple students, being able to support local areas like Kent and Case Western and other area programs by training their students in the ways that we have learned and know speech language pathology, so that we can send them out into the world, much like residents are sent out into the world from the physicians and other staff here. And then finally, opportunities for SLPs to be protected in terms of the research time that they have. So right now, all of the research time, for the most part, is, if you will, nights, weekends, and extra moments that they have during the day in order to collect data. But with funding from external sources or even internal sources, we may be able to get some more assistance and have larger projects. And that would be a 5-year vision. And as you can imagine, sky's the limit with regard to the 10 years. We'll see where that goes. But I certainly welcome everybody to join me on that vision and to join me in those goals. I'm going to leave everybody with a shout out for the Dysphagia Research Society's March meeting next year. Will be in San Juan, Puerto Rico. As always, it's going to be a fantastic meeting. We would love to see greater involvement from Cleveland Clinic and welcome everybody there. You can go to dysphagiaresearch.org for more information, and I will leave it there.
Well, thank you so much, Dr. Brodsky. It's a very exciting vision. I really appreciate the presentation. We have a few minutes left. I wanted to open it up for questions from our audience.
Yeah, so Marty, this is Brandon. Great presentation and kind of summary of what you guys are doing. And I think you might know that Will Tierney is kind of hosting one of the tracheostomy panels at Academy with Dr. Pandian, who you know from Hopkins really well. And I think there's just tons of opportunity here as well along that kind of tracheostomy, pathway. We have 300 plus tracheostomies a year. So I think the work that she and you guys have done at Hopkins is really probably applicable to what's happening here in our institution. So would love to see how you guys explore that.
That's fantastic to hear. I absolutely support that effort in every possible way. Vinci and I are in frequent touch. I even spoke with her 2 days ago, and I've gotten emails with her all the time. I get global tracheostomy knowledge, all the handouts from there as well. So not just local, not just national, but global tracheostomy is across the world, and perhaps their interests in expanding to that level as well.
Yeah, I also I wanted to make a little plug for innovation. You know, in speech language pathology, you get to interface with patients across a spectrum of the sort of care continuum, outpatient, acute care, oncology, and I would just ask people to keep your radars up, use us all as resources for possibly some really patient-centered innovation and designs. Marty highlighted so much that the group is doing. I wanted to just give a little shout out to Michelle Odessa and the Voice Center for some of the just curiosity and inquiry and willing to kind of work with patients and identify problems. To come up with or at least explore an interesting oral cavity device, for tongue strength. So, as you all look out with this, I think there may be some opportunities for sort of novel programs, devices, and things that So I would say let your minds wander and feel free to to see if you think there's a solution for a patient with this whole host of pathology that you encounter. I would encourage you to write it down and to put it forward.
Absolutely. I'll do whatever I can to support that.
What else? We're at 8 o'clock. Well, maybe one more question, and then we can get on with the day of care. Well, congratulations, Marty. It's great to have you here, and we're certainly excited for the future and opportunities to collaborate, not just in our institute, but really even more broadly in the whole hospital and enterprise work.
I look forward to it. It's very exciting for me to be here, and I'm energized. Bring it on.
Well, thanks everyone for tuning in for Head and Neck Live, this today, and hope everyone has a nice day.